Hello everybody, welcome to this afternoon's discussion. My name is Bronwyn Delaney on behalf of Metaphorical Therapy. I'd like to welcome you. Joining me today, I have Professor Phillip Morris and Dr. Mark Whittington. Phillip is a specialist psychiatrist in psychogeriatrics, adult psychiatry and addiction medicine, among other significant professional credentials, which will be linked in his bio below. Also joining us is Dr. Mark Whittington. Mark is a consultant psychiatrist with extensive interest in anxiety, depression and PTSD, as well as co-founder of Metaphorical Therapy. So welcome, gentlemen.
Hello, good afternoon.
Okay, so today we're going to be touching upon the scale of the Australian mental health crisis. And we're going to be talking about the problem, prevention and support on how to help the suffering Australians who have got anxiety, mood disorders, PTSD. So I'm going to start with you, Professor Morris, and ask you, do you agree that there is a mental health epidemic in Australia, and more so since COVID?
Well, I'm not sure whether it's an epidemic, but there's certainly been a huge demand since the COVID pandemic. And that's been demonstrated both in the public sector, but very much in the private sector, because all my colleagues in private psychiatry have got waiting lists that now, unfortunately, go up to 6 months. And while that might be seen as being positive in one way, it means that a lot of patients are going to have to wait a long time before they get seen by a psychiatrist. And the other thing we know is that there are probably around about 40,000 psychologists in Australia. There's only about maybe 3,000 to 4,000 private psychiatrists in Australia, but there's 40,000 psychologists. And according to my psychology colleagues, they're all pretty busy as well. So this is it's unprecedented. We often hear that word, don't we? But I've never really seen anything in Australia where the demand for mental health services, both from psychiatrists and psychologists, has been so high. And probably it's partly due to the pandemic, but also partly due over many years to destigmatization of mental health problems. And I think people are more able now to acknowledge that they do have a difficulty and they need some help for it, because they've seen, very important and high profile members of the community talk about their own problems with depression and anxiety. But yes, it's certainly been, in the terms of whether it's an epidemic, we usually refer to epidemics to be things related to infections or infectious agents. So I don't think we'd say it's an epidemic, but certainly it's a profound increased demand for services.
Right. So, Dr. Whittington, just on the scale of the problem, obviously there is a range of afflictions that are affecting people, and some who are, hospitalized, and others who are more among the walking wounded, people who are maintaining jobs and sustaining their family roles, but certainly suffering. For those people who are afflicted by anxiety, depression and PTSD, what kind of support is effective for those types of patients?
Well, patients who get to a psychiatrist are usually fairly seriously ill, notwithstanding the long waiting list for which the GP has asked for additional help. Many of them will also concurrently be seeing a psychologist. So what supports are available to them and what is required? It's psychoed, it's support, acknowledgement, understanding, and there's treatment. Now, psychiatrists will focus on the biological treatment. By no means is that all we do. In fact, there's quite a significant overlap between what a psychiatrist will do psychotherapeutically and in the cognitive behavioural area as the psychologists. But certainly there is a great need for both the psychological and the medical side to be treated.
Just on that thought about the psychological side, obviously patients who are presenting for urgent care in a medical setting versus patients who are trying to source help and intervention, say via technology or ancillary sorts of or complementary therapies. What type of delivery do you think has been, obviously with COVID, people have become accustomed to telehealth. What about the other kind of complementary services and in particular, speaking to metaphorical therapy and its delivery to patient care?
Well, one of my motivations was, because we're so busy, and you're only seeing one person at a time. The whole metaphorical therapy came about as providing education and treatment to people digitally, and not just restricted to the delivery of one person one-on-one. So what I've tried to do is create some basic principles that help with the prevention as well as the treatment of mental health problems. So the aim really, and this has really been the driving force, is prevention. Prevention of mental health problems by understanding what are those principles. And if we ask Phillip, I mean, you know, what do we actually teach people about looking after their mental health or preventing their mental health? As far as I'm aware, not too much.
Well, yeah, probably right. There are some things around that have been put in certain situations. There's a thing called mental health first aid. Now, that's a training program for individuals who might be looking after patients, like it might be a family member, maybe a mum who's got a son who's got schizophrenia, or it might be a member of the emergency services and others. There are training programs for people to get some more experience in dealing with individuals that have mental health problems or substance abuse problems. It's something that I think is very good, but it's not widely available throughout the whole community. And it does cost some money for people to do it. You've got to have a trainer, and then you organise groups. We've done this on the Gold Coast. When one of the times I was president of the Gold Coast Medical Association, we had an opportunity to train a number of members of the community, and we got them to write a letter as to why they would like to get the training. And it was quite amazing the number of people that said that, you know, they had a family member who had a psychiatric problem, maybe bipolar, and they'd like to get to know how they could better help them in the future. So that's available, but it's not widespread available. I think we've got a lot more to do to educate the community about what things can help both prevent getting mental illness. That'll take a while because we don't know a lot of things about how to actually, you know, what causes mental illness, but there are certain things that people can do, exercise and making sure they don't get isolated. They're two most important things. And then what things can be done to help individuals who might have developed symptoms and a way that they can best manage those, maybe until they do get to see someone like a psychologist or a psychiatrist or even their GP before they're seen. So I think this type of activity that you've developed will go a long way to providing the community with some more tools to use when they're feeling distressed and looking for ways to help themselves.
That's interesting, because when we're talking about special groups getting assistance and people get burnt out and looking after mentally ill or even just the elderly mother or parent, it's exhausting. So what I tried to do is crystallize those key fundamental principles, because we aren't taught, you know, how do we look after our health? Yes, you know, exercise, and yes, get good sleep. But if I introduce self-preservation as an overriding principle, that's the same for everyone. I've got to look after myself. You've got to look after yourself before you're going to be able to look after anyone. And so I prioritize that, and I present it in a novel and provocative way, and digitally delivered. So I think that the potential benefit is getting in on the ground and really getting in the fundamental principles before a person gets symptomatic. And rather than an individual approach, there is a sort of a universal sort of, you know, principles that everyone can learn and can benefit from. That's really where I'm coming from. And look, it works with my patients, and it's been very, very effective. And that's been one of the reasons why I've really pushed this onwards, because I've got some personal, you know, clinical results just one, and I'm just extrapolating in the digital arena.
A question, Professor Morris, for you is, obviously there is a component of self-care involved in an individual picking up one of these therapies and actually running with it, either in between appointments or hospitalizations. How effective is self-care in mental health?
I don't think I can give you any specific figures about how effective it is. I suppose it depends a little bit what you mean by effective. Does it give the individual some sense of power in their situation to do something. And we know that, you know, it's awful when everything's happening to you and you don't have anything to do in terms of trying to control your environment. And that leads to a great deal of despondency, and it often leads to isolation of the individual. So if you give someone a tool set or some guidelines that they can use themselves, then even if the guidelines aren't necessarily the best in the world, the fact that they're doing something positive to assist their circumstances, to help them cope with the stresses that they're facing, is a lot better than just being sitting there and having all these things wash over you. So I think from that perspective, there's some benefit. How much benefit? I don't know the figures to be able to tell you the answer to that question, but my gut feeling is that it's very important that we give the community and, as Mark was saying, individuals, even before they develop symptoms, an opportunity to use techniques and principles of life that give them control back, and so that they're not feeling as if being overwhelmed, and also to allow them to sort of talk to others so that they don't get isolated, and talk about what's happening in their own lives and how they're doing something about it, you know, on a more positive level. So I would think that that would be all very, very good.
Can I ask you, Professor Morris, about your, Mark's talked about his development of this idea of metaphors and creating a resource for people that they can self-soothe with by internalizing the metaphor and its meaning personally. Do you see the value of that in practice? Have you got any thoughts you'd like to share with us just about how an individual can apply their own beliefs to their own creation of well-being?
Well, I think the idea of metaphor is good because, I mean, psychological problems, psychiatric illnesses and things are sometimes very difficult to understand. That it's hard to put them into concrete terms. And so if you can get something where a person can look at a picture or identify a feeling through looking at something that's a metaphor, then it gives them a language to talk about these things, because sometimes people just can't talk about the feelings that they have because they're not familiar with being able to speak in that type of language. I mean, we as psychiatrists and psychologists get experience with this over a lifetime and a career. I mean, it's our bread and butter. But not all people are exactly familiar with these feelings and can articulate their feelings very well. But if you show them a picture and that makes sense to them, then all of a sudden a little light bulb goes on and says, that's what I've been experiencing. And so then they can take the next step and say, well, what can I do about that? And move on. So I think the idea that you can put these metaphorical concepts will help a lot of people. It won't help everybody, but it's another tool for a person to try and understand their situation. And understanding their situation then allows them to take the next step to get either help or to start managing it better themselves.
It's interesting you say that, Philip, because metaphorical therapy at the speed of sight, we use metaphors and we use visual metaphors. And you know, a picture tells 1,000 words. A visual metaphor intuits 1,000,000 is what I say. There is so much more, a payload of meaning captured or carried over from the metaphor. And let's just, by way of example, I say that self-worth, the third keystone principle, is measured in gold. Gold, your emotional gold, your time, love, and energy is precious like gold. Gold is invested in people, your friends and family, according to the equal is reciprocal principle. So I say a peripheral friend, a little investment, and as our relationship grows, a major investment. But if it's healthy and equal and it breaks down, then we both lose. But if it's imbalanced, and I've given you this and you've given me that, I lose everything, you lose nothing. So using the metaphor, carrying over meaning, making, as Philip said, something ambiguous and unclear concrete, now quantifies what the person's dealing with. Now self-worth is gold. Now gold is invested. Now I want a return on investment. So what we've done with metaphorical therapy is cognitive behavioral therapy by stealth. we've inadvertently changed the whole framing of how a person sees their self-worth. One, my self-worth is gold. My gold is precious and rare. I have the gold of a life partner or best friend to invest because I want a return. There's difference between a donation, I don't get a return, but I invest in my friends and family because the last time you don't want to find out who your true friends are in a crisis. According to metaphorical therapy, you know already because you've already tested the relationship to make sure it's healthy and equal. Then I draw a distinction between an investment and a donation. A donation, I don't expect a return, but I don't donate my gold, my money to the alcoholic outside the pub or the gambler outside the casino. I value my time, I value my money, which is my gold. If I'm emotionally, if I have healthy relationships, I'm emotionally equal, I can make more donations. So actually, it's good to make donations, but first and foremost, I must be healthy. Now, I put it to Phillip that if people had healthy, equal, and reciprocal relationships, then they are at less risk of anxiety, depression, because people actually get destroyed because they've invested too much in it, or burnt themselves out because they've done all the right things, caring and helping everyone else, but they've thought that it doesn't have to be reciprocated, it'll automatically come back. So I sort of have a transactional, relationship as I talk about gold invested. And you'd be surprised how powerful that actual little conversation is, because it's not cognitive behavioral therapy challenging what you're thinking. It's a whole new framework of understanding, which now recalibrates how a person looks at their relationship. Are they healthy and equal? Am I getting a measure of what I get back? And it changes their behavior, which is one of the inspiring things I have about metaphorical therapy. People change really quickly because they kind of like get, oh, that makes sense. And when it makes sense and it has a truth to it, then a person is more likely to change their behavior. Does that sort of...
Professor Morris, just leading on from that, obviously when people present at your practice and to the system and they're unwell, there's an intensive treatment phase, but at some point I would anticipate there is a skill building stage to actually take people forward in life, and once repairs have been effected through appropriate interventions, do you see that there is the ability to actually deliver skill building support and education outside of like that clinical face-to-face setting using apparatus like this kind of support?
Well, I'm sure that there is. I mean, I think this is one of the many techniques that are being built to try and support people who may go through a period of active treatment with, maybe it's their general practitioner or their psychiatrist or their psychologist, and then to provide follow-up and ongoing care, and in a sense to help them establish and to solidify the changes and extend the changes. And so I think there's a number of, particularly ones done now by the internet, techniques which are being put forward as being ways that we can do that. So I think Mark's model is another way of helping in that regard, and we'll see how well it works over time. I mean, we're all in a new phase now where people are being treated in a sense remotely. We see a lot of patients, Mark and I do now, on telehealth, which is not something we did 10 years ago. So that's a new thing, and now patients are able to get, and if they're not patients, they may be just members of the public, but as Mark says, they might be dealing with some difficult situations. They can get assistance online through programs that sometimes they can get for free and sometimes they have to pay for. So it's a whole new world. How effective all these things down the track will be, well, time will tell, because we're still in the early phases of all of this.
It strikes me that therapies or activities like this can perhaps open a door for people who would otherwise have been reluctant to seek help, that they're a stepping stone potentially into a pathway into deeper treatment. Mark, have you found over the course of your practice and using metaphors within your practice that you've deepened people's curiosity and enthusiasm to actually affect change in their life basically using them to build momentum to actually get more excited about their treatment and feel more hopeful and optimistic, especially around mood disorders and things that have been really sort of suppressive and pervasive. Where is, I suppose, where is hope in all of this?
Well, the way I see it is that metaphorical therapy teaches people to swim, not just saving. That metaphorical therapy gives you a formula so you can work out the answer. So people come to us with problems and they leave my practice certainly with skills to able to avoid or reevaluate where they've gone wrong, because anxiety and depression doesn't happen in a vacuum. And people get sick because of context and reason, whether it's work stresses, whether it's relationship or family dynamics and everything like that. And so it's important to give someone the skills with which to be able to, to be able to go forth and perhaps have better health.
Professor Morris, just in terms of the continuum of demographics that you see in your practice and the delivery of mental health services, do you see older patients responding to digitally delivered health? Obviously, they've had telehealth appointments, but could you see patients picking up, potentially apps or podcasts or other activities to support themselves? Are they creeping into the discussion that you're having with patients?
Look, they are to some degree, although I look after patients now who have memory problems and often are in their 70s, 60s, 70s, 80s and 90s. Some of them will be pretty savvy with computer technology and will be comfortable doing that. I'd say the majority will be preferred to doing investment the old-fashioned way, one investor at a time, or one patient to see the doctor in their office. I'm more familiar with that, but there'll be a proportion that will look at these techniques and think that, can I do this online? I think it's a smaller proportion in the older population. It will be in the youngsters who have basically grown up with handheld devices since the age of about 5 and can use all these things very adeptly. But there's no reason why an individual older person in the community, an older patient, cannot benefit as long as they're comfortable with the technology.
And just finally, we've talked a lot about how these kinds of interventions can work, but in terms of the scale of the problem, how pervasive is the mood-based disorders in the community, and what do you think they're costing the economy in terms of work and lost man hours and lost participation? I mean, how big is the bite that we're trying to take out of the apple here?
Well, a number of studies over the last 10, 20 years have looked at the proportion of the population that are affected by mental illness, and we have pretty good figures now, and they're fairly consistent, that about 20% of the population at any one time have a mental illness. And of that group, maybe sometimes it's up to 25%, but of that group, the anxiety disorders are very common, and the depressive disorders are very common. Then after that, you've got the drug and substance abuse disorders. They're primarily alcohol is the most common there, but then you've got the other addictions. And then after that, you've got the conditions that we know as bipolar disorder and schizophrenia and those ones, which are around the 3 to 5% of the population. But the mood disorders, if you categorize them fairly widely as both acute and ones that are more chronic, there'd be around about 10%, up to about 10% of the population. So that's a big chunk of the population have a problem in any one year. And then, if you look at it over a lifetime, the levels are even higher. And we know, of course, psychiatric illnesses are chronic. We'd like to think that they just happen once and they never come back. But we know from looking after our patients that people who get depressed may get better, and that's great, but they often are more susceptible to getting depressed later on if they run into another particularly difficult period of their life. So it's a big problem. We've got to be hopeful because we can help people a lot, and we can reduce the trauma and the disadvantage that's caused people by getting depressed these days with our treatments and encouragement. but it is a big part of the population, and it affects everybody. It affects people who are working. There's a thing called presentism. That's people who go to work, are depressed or very anxious. They stick at work because they're good workers. They want to do the right thing by their employees, but they're nowhere near as effective as if they were not depressed. The other group, of course, get depressed and they go home because they can't go to work. But you've got people who are at work who are depressed and people who are at home are depressed. So if you can get this treated, then the productivity for the whole country will improve.
And just touching back on the statistics earlier that you mentioned about the number of practitioners and psychologists and psychiatrists, how many people do you think are effectively, as just a rough percentage, how many people do you think who are afflicted are actually connecting with services at the moment?
Well, that's a very good question, because you see those figures that we do when people go out and do surveys, they're usually trained. They're not necessarily psychiatrists or psychologists, but they're people who are trained to actually give an interview, a clinical interview, but they read it off and they're trained to give the interview, and they go out and see people in the community in a census type activity. And that's where you get those prevalence figures of how many people in 1 year have a mental illness that I quoted before. The big issue is not only do they have a mental illness, but how many of them are severe versus how many are mild, and how many would really benefit from treatment. So the numbers that are severe, of course, are much smaller than the numbers that have a mental illness, because severity is another dimension other than having the symptoms. It's also how severe the symptoms are affecting the individual's functioning. And then how many of those who really should be getting treatment are getting treatment. And we know that there's a big gap between those who have mental illness that are reasonably severe and those who have mental illness severe who are getting adequate treatment. And it's now called the gap in the middle, or there's a name for it, but it's these people who are not severe enough to need hospitalization in a mental illness hospital, but they're not getting the care that they need. And so that's where perhaps Mark's activity will provide some assistance, I think.
So Mark, understanding there are lots of patients who are the walking wounded and they're episodically unwell, how would you see metaphorical therapy playing into their support?
Well, one thing, it's easily digestible, and because it's pictures and metaphors, it's really simple and easy to digest and understand. So even the acutely unwell person will get something out of metaphorical therapy. Sometimes those pictures just grab and resonate with the patients, something we hear all the time. But over and above that, it's one thing saving the person, it's another thing preventing them from becoming unwell. And this is where I see the real benefit of metaphorical therapy is going forward. It'll give people some more skills about how to cope in the future. One of the things that I'm particularly interested in that came out of the Dunedin longitudinal study was you need to get it in early in terms of education and prevention. When a person's fallen over, as Phillip has said, they often go on to have a recurring problem. So the idea is to try and get in there early, and any intervention early saves dividends in the longer term, and that's really where I want metaphorical therapy to go in the future, is in that prevention and early intervention area.
All right, excellent. Well, gentlemen, thank you very much for your time this afternoon. For viewers of the webinar, we'll have links to metaphorical therapy as well as to the bios of Professor Morris and Dr. Whittington. Thanks very much for joining us.
Thank you.